I am Giuseppe Rosano. I'm Professor of Cardiology at St. George's Hospital, University of London. Um, what I'll do in the next 25 minutes is to discuss the importance of biomarkers in acute coronary syndromes. Now, we know that in patients with an acute coronary syndrome or an acute myocardial infarction, time is life. And we also know that each year, 7 million people suffer an acute myocardial infarction worldwide. That acute myocardial infarction, despite all the improvements that we've had in the past 30 to 40 years, is still a life-threatening condition because it's still associated with a 9% mortality in patients with STEMI and up to 11.6% mortality at 1 year in patients with STEMI. Now, it is important to look at the mortality at 1 year rather than the acute mortality, because the more we wait in intervening in patients with an acute MI, the greater the damage, and therefore that will reduce the probability of survival. In fact, every 30 minutes of delay between symptoms and treatment, there is an increase in the risk of 1 year of mortality at 1 year of 7.5%. So we need to be quick in decision making and in intervening. Therefore, every minute counts, and there's a need to identify and stratify patients that on one side will need an immediate treatment. On the other side, they will need to be stratified as low risk. So where we can wait, we can do other type of testing like a CTCA, for example, or where we can rule out the acute coronary syndromes. So therefore, it is important to make a diagnosis in a shorter time, possible time. And we have, of course, the biomarkers and the combination of biomarker ECG that will give us a very good help in saving times. Of course, we have the different way of measuring the cardiac enzyme. And we know that the ESC guidelines suggest that together with the 12-lead ECG, the 6-9 hour observation with if you use a conventional troponin, cardiac troponin tests. However, it is possible to use T0 3 hours or a T0 1 hour rule out protocols using the high sensitive troponin. I mean, this is a big advantage, of course, and we will discuss that later. So we have the conventional troponin tests that will need up to 6 hours in order to rule in or rule out. Of course, we have the high sensitive troponin tests with 0, 3 hours. And then it is important to see whether we can reduce the time to diagnosis and in order to have a faster rule in and rule out and a faster appropriate therapy and reduce the ED burden. But also now we have the high sensitive cardiac troponin T that will, as I will show you later, will shorten this time in to 1 hour. So the first study that looked at the possibility at 1 hour of high sensitive troponin T algorithm was the Apache study. It was a retrospective pilot study in patients that were presenting to the emergency department with within 12 hours from chest pain. And it was mostly based on an algorithm that looked at the sensitive troponin T baseline value and the absolute change within the first hour. So the patients were allocated to one first algorithm. Those patients that at presentation had a high sensitive troponin T less than 12 nanograms per liter, and within the first hour had a variation that was less than 3 nanograms per liter. And in these patients, they could have been ruled out. Then there was a clear cutoff for ruling in, and that was those patients with a troponin, high sensitive troponin T greater than 52 nanograms per liter, and a delta greater than 5 nanograms per liter within 1 hour. And then, of course, we had a gray zone of all those who were in between that were kept into the observational zone. So if we look at the results, we see that 60% of patients were ruled out with a sensitivity and specificity of 100%. So it was very specific. So this new way, a new algorithm, and of course, the new way of measuring the troponin T with the high sensitive standards has a very high sensitivity and specificity, and identifies those patients that can be sent home or can be observed if needed. Then there were others, the patients with a clear-cut high troponin T, where that represented 17% of patients, and in this group there was a specificity of a very high specificity, 97%, with a very high positive predictive value. And then we had the observation zone. Observation zone, of course, included patients with a wide range of troponin, where patients were observed, and these were 23% of patients presenting to the emergency units. And in this group, there was a prevalence of an MI of 8%. So then there are two Apache studies that were conducted one after the other. The first one in 2012, the second one in 2015. And basically, they've used the same algorithm to rule in and rule out the presence of myocardial infarction. You can see that the results were pretty consistent between the two studies. Sensitivity and specificity to rule out was 100% in Apache 1, and Apache 2 was 99.79%. So basically, that shows that this assessment, this way of assessing with the high sensitive troponin T, is very effective to identify those patients who can be sent home. Then regarding patients that had to be ruled in, there was still very high specificity. There was around between 97 and 95%, so extremely high for those patients with a cutoff greater than 52. And in the those who were kept in the observational zone, we have a prevalence of MI of ranging from 18 to 19%. Of course, this observation zone can be can vary according to patient characteristics, where the emergency unit is, and but that is a very effective way of measuring. So the high sensitive troponin T approach was validated in over 1,700 patients, and managed to rule out the acute myocardial infarction within 1 hour in more than 75% of patients. So you see how cost effective this protocol, this way of measuring high sensitive troponin T is, because then it means that you can get safely discharge from the emergency department patients with 75% of patients within 1 hour. And so you significantly reduce crowding in the emergency unit. Now, it is important to look at the 0-1 hour algorithm, and Christian Müller led the RAPID study that was published in the Annals of Emergency Medicine. The TRAPID AMI study was a multi-center international studies that was across Europe, America, and Australia. included many centers in many European countries, ranging from Italy, Switzerland, Spain, Germany, Sweden, Belgium, and the UK, and centers as I said, in America and in Australia. The study design was basically at the aim to validate the diagnostic accuracy of the 0-1 hour algorithm using the eye-sensitive troponin T for the rapid rule-in and rule-out. So the patient population included nearly 1,500 patients presenting within 6 hours. In this case, you've seen before were patients within 12 hours, but now less than 6 hours of symptom onset, symptoms suggestive an acute myocardial infarction, and also early presenters within 6 hours of chest pain. 176 patients were excluded because of inappropriately timing in blood samples. So the study was very rigorous. And of course, the exclusion criteria were all those confounding factors that may have affected the results of eye-sensitive troponin T, like terminal kidney failure, dialysis trauma, pregnancy, or prior cardioversion or defibrillation, where of course there will be higher values of troponins. The first blood was drawn at time 0 when they presented to the emergency department, and additional samples were taken at 1 hour. That was the cutoff for the study, but also later samples at 2 hours and later were also taken. It is important to also to look at how rigorous was the study, because the final diagnosis was adjudicated by 2 independent cardiologists that used the universal definition of MI and using the high-sensitive troponin T, but also in order to keep the blinding, the troponin E was also used for adjudication in order to achieve a complete blinding. So doctors were blinded on the results of the high-sensitive troponin T, all those who have adjudicated. And if we look at the results, where there's 1,300 patients, and again, looking at those who presented with high-sensitive troponin T less than 12 nanograms per liter, and less than a variation in a variation degree less than 3 nanograms per liter, there was a sensitivity that was extremely high. It was 96.7%. So that tells you that you can safely discharge the almost all patients within 1 hour without any doubt. And also the specificity for ruling in was very high, because it was 96.1%. So basically, within 1 hour, you can easily identify all those patients who need to be sent to the cath lab, thrombolysis, whatever intervention is available. So if we put the 2 Apache studies and the TRAPID AMI studies together, we can see how consistent the results of the eye-sensitive troponin T assay is in both ruling out patients with an acute myocardial infarction, but also to rule in, and therefore to allow, first of all, avoid crowding of the emergency department. And this is extremely important now in times of COVID, where, of course, because of the social distancing, we need to have more space in the emergency department, and therefore we can see less patients. And so reducing and ruling out patients and sending them home is crucial. But also it is crucial for patients to be identified very early in order to be sent to intervention. If we look at the prevalence of MI in the group of others, so those with either a troponin algorithm that were troponins that were greater than 12, or with a delta greater than 3, then we can see that the prevalence of MI ranged between 22 and 8%. So that tells you that basically you can safely rule out those where it's very negative. You can rule in those where it's very positive, and you can keep observing the remainder. And the remainder is only 20% of patients. So you basically have reduced by 80% the number of patients that you see. Now, if we look at the algorithm and we look at the consistency of data, we can clearly see that the eye-sensitive troponin T assay is extremely sensitive and specific. And because it shows, this shows you the negative predictive value. And you can see that there's no difference between male and female, younger and older patients, patients with proven pre-existing coronary artery disease or without known pre-existing coronary artery disease, patients presenting within 2 hours more than 2 hours, and patients with normal EGFR or patients with reduced EGFR. So it is a very sensitive and specific assay. Also, if we look at, and this is very important because when we look at the 30-day overall mortality in patients where MI was ruled out because of high sensitive troponin T that was very low, or and less than a delta of 3 nanograms per liter, you see that the mortality was 0.1%, the mortality for all causes, which is even lower than what you expect in a general population of asymptomatic patients. In those patients that were ruled in, the mortality was 2.7%. And that is also important because it shows you that a faster diagnosis enables an early intervention and therefore reduces mortality. And those in the observational zones were 0.7%, therefore suggesting that in those patients where there's a doubt, the serial measurements will enable a more accurate diagnosis of these patients. So this data basically support this protocol for a very early discharge. Now, also, the TRAPID AMI study showed that there is the high-sensitive troponin T assay is safe and effective way of rule in and rule out in 1 hour. That was the first multi-center international study to prospectively validate the fast 1 hour algorithm in the early presenters. So those patients who come to the emergency unit within 6 hours. And this algorithm performs very well for early rule out and rule in of myocardial infarction. 63% ruled out for an acute myocardial infarction within 1 hour. So excellent values and to save time and money. And this is the safety is also confirmed by the 30-day mortality of patients where they were ruled out, and is endorsed by the guidelines of the ESC guidelines. So that as I said, it is important to see the consistency of data and how the specificity. So basically now we have 3 studies that show how the high sensitive troponin T 0-1 hour protocol is very safe and effective. There is a consistency of results in studies conducted across different times and across different regions, showing that a sensitivity and specificity of nearly 100%, and to rule out, and specificity and sensitivity of 97% to rule in. So this is the data very consistent. But also what is important is that other studies have shown that using the levels of the troponin T levels with the eye sensitive for an MI cutoff were associated with a reduced mortality risk. Because if you look at patients with acute coronary syndromes, you see those were that in those where the high sensitive troponin T assays were used at a significantly lower mortality at 1 year compared to those that were other assays were used. And the same is true also for those patients that were ruled out for with the 0 1 hour protocol. And this is both in patients with acute coronary syndromes and those without acute coronary syndromes. Also, other studies have shown that using the high sensitive troponin T, there is a reduction, a significant reduction in costs, both not just because of the reduced timing in the emergency department, but also because there is a less use of cardiac tests, cardiac SPECT, and exercise ECG, whilst there was no difference whatsoever in the use of coronary angiography or angioplasty. That means that tests are still are performed in those patients where it's needed, and patients who are needed to be sent to the coronary angiography or angioplasty are sent promptly. And if you put this data together with the previous one, these patients are sent to the cath lab earlier and therefore have a lower mortality with using the high sensitive troponin T tests. So the impact of this last study is very important because it's basically showed that there's the FAST protocol did not lead to an increase or inappropriate use of coronary angiography. And because you would have thought that just in order to be safe, patients would have been sent to the emergency to have a coronary angiogram anyway, and that was not the case. There was a reduction of stress testing that more than 30%, reduced the time spent in emergency department by nearly 80 minutes, and the eye-sensitive troponin T was associated with a 20% reduction in total costs. So it is important to understand that why we need to introduce this new method of assessing cardiac damage or to rule out the presence of an acute coronary syndromes using the eye-sensitive troponin T. Another study was the study that looked at the effect of serial high-sensitive troponin T. So another study that was important also to look at the importance of the whether we need serial high-sensitive troponin T measurements was the one conducted by Müller-Hessen. They looked at the serial sampling of high-sensitive cardiac troponin T, trying to demonstrate that this was not required for the prediction of acute myocardial infarction. This was based on the background that the guidelines still used to suggest, and in many countries that people still use the dynamic changes and of the troponin T in order to rule in and rule out patients. So the test was to see whether the high sensitive troponin T improves the diagnosis of acute myocardial infarction in acute patients with a highly abnormal baseline troponin T. Now, you can clearly see that if we look at those patients where the high sensitive troponin T eye sensitive was used with the addition of a 1 hour change, you see that the positive predictive value was absolutely similar to those who looked at the absolute change. So basically, that tells you that adding 1 hour or 2 hours changes in the high sensitive troponin T basically did not improve the positive predictive value in patients with high sensitive troponin T. So if we find the troponin T, high sensitive troponin T that is greater than 80 nanograms per liter, basically we can easily and safely make a diagnosis of an acute myocardial infarction without any doubt. And if we, in those with values below below 80, then we need to add the 1 hour. And you can see that the 1 hour was the absolute 1 hour change. Using the high sensitive troponin T, the positive predictive value is very high at any value of the high sensitive troponin T. So at the end, I think I showed you that it's why we need to use a measurement of high sensitive troponin T with the 1 hour algorithm, because basically this reduces the observation time. It is faster, is supported by the guidelines of the European Society of Cardiology since 2015. And if we make a quick diagnosis, we save mortality. We reduce mortality. And therefore, as I showed you, the approach using the high sensitive troponin T is indeed associated with lower mortality compared to using other assays that will delay time to treatment. So using in conjunction the electrocardiogram, the other informations, and the high sensitive troponin T, the TRAPID MI basically demonstrated a rapid rule out and rule in of patients with who did not have any acute coronary syndromes or had needed to have a faster intervention. And that basically, the beauty of this new way of measuring troponin T is that it's the 1 hour algorithm accelerates the diagnostic procedure. But together with that, that has a very important impact in terms of cost saving, because the faster initiation with the application of the TRAPID MI algorithm reduces the need of extended observation, optimizes the resource, and help the allocation of resources in the emergency department. So what are the conclusions that we can draw from TRAPID MI? But also, I would say, by all the studies that preceded and the other studies that followed TRAPID MI, basically is that the high sensitive troponin T is safe and effective in ruling in an acute myocardial infarction at 1 hour. If we look at the change in troponin T, this has been the high sensitive troponin T with the Roche assay validates the use of the high sensitive troponin T with a delta change. Then we have 3 big studies that have used the 1 hour algorithm in more than 3,000 patients. And we also know that the high sensitive troponin T algorithm rules very well in an early rule out of and rule in of acute myocardial infarction, reducing time to diagnosis to 1 hour in nearly 80% of patients. But also, there's this is a very good performance because it's associated with nearly 100% negative predictive value. So the algorithm basically confirms its safety by the and this is confirmed by the extremely low 30-day mortality. It was 0.1%. Basically, it was is lower than the general population without any symptoms. So using the 1 hour algorithm, it means that we can use more patients to be tested, more early presenters, and basically the 1 hour algorithm using the high sensitive troponin T makes a big difference compared to all other standards that we have because of the clinical implications, the economic implications, but also the benefit to our patients. Thank you very much for your attention.